So if you see, the main organ in the body that is responsible for regulating our body temperature is the hypothalamus. And it's very important to regulate body temperature because all our, the body is actually a machine. If you've seen, all machines require an optimal temperature to operate. And in our body, there are so many enzyme reactions which are occurring. And as you know, that all enzyme reactions are temperature dependent. So if the temperature is going to vary beyond a certain point, the enzyme systems are going to break down and the body's physiologic processes are going to suffer. And we've seen that whether there is a hyperthermia or a hypothermia, there is a multiple organ dysfunction that ensues, which is directly proportional to the degree in which the temperature dysregulation has occurred. So basically, the hypothalamus, as the blood temperature lowers, okay, because we average a blood temperature on 37 degrees Celsius or about 97, 98 degrees of Fahrenheit. And as the temperature starts to fall, the hypothalamus kicks in certain warming mechanisms to try and bring up the body temperature so as to make us homeothermic. Homeothermic meaning that we are able to regulate our body temperature within certain limits in spite of changes in the atmospheric temperature. And that's very important because that allows us to live in different climates and survive and even thrive out there. So I'm not able to scroll this down. Can you just check that? Yes. Okay. No, it's not scrolling. Yeah. Okay. So again, the hypothalamus has got its effector mechanisms through the nervous system, the autonomic nervous system, in which the sympathetic nervous system plays a very major role because we tend to lose heat through three main mechanisms: conduction, convection, and radiation. And a lot of it has to do with the amount of blood flow which is going through the capillaries in our skin. Okay, so if the capillaries are dilating, then there is a lot of heat transfer to the skin from where it is lost to the external atmosphere. And obviously, when there is a change in the environmental temperature where it starts becoming progressively cooler, what happens is that the hypothalamus kicks in a warming response where through a sympathetic outflow, the blood vessels constrict. And that's how the individual starts feeling a little cool in the skin. Secondly, the body metabolism is upregulated, and that is done by increasing the tone in the muscles. So the muscles start having a shivering. Now, shivering is not actually tetanic contractions, but it is an increased tone in the muscles in which there is an increase in tone, then a slight reduction in tone because of the reflex feedback through the muscle spindles. And the shivering is actually just an increased tone. So there's no actual contraction relaxation occurring, but the increased tone is kind of intermittently getting reduced because of the feedback through the muscle spindles. Also, what happens is that the thyroid hormone, because the hypothalamus just lies above the pituitary gland and it releases TRH, thyrotropin releasing hormone, and the TRH then goes to the pituitary, and from there it releases TSH. TSH goes to the thyroid and releases the thyroid hormones, which upregulate the body metabolism. Okay, so this is the way in which the hypothalamus would help in regulating the body temperature when it is cold. Now, again, if you see that as the capillaries vasoconstrict near the skin surface, there is hardly any blood flow at the skin, and the skin and the underlying subcutaneous tissue, especially the fat, has an excellent insulating ability. Okay, so the greater the amount of body fat, the greater is the insulating ability. And what is also very important is that as the hypothalamus causes more and more release of impulses to the sympathetic nervous system, the sweat secretion ceases. Okay, so that because sweat is a way in which we lose heat through evaporative cooling. So the sweat secretion ceases, and there is something called as piloerection. This piloerection is when all the hairs stand up on end, which is especially important in animals who do not have, a three-piece suit to protect themselves or some, warm blanket. And the standing up of the hairs actually traps a layer of air just next to the skin, which itself also has an insulating effect. Okay, so again, coming into this, what we are talking about is that there are peripheral receptors for the cold. There are peripheral receptors in the skin also for warm sensations. Now, the cold receptors get activated when the external temperature starts to fall, and they send in impulses through the spinal cord into the hypothalamus. What the hypothalamus then does is that it sets out the mechanism I just discussed previously, the vasoconstriction of the skin arterioles, the stopping of the perspiration. And in fact, it is very, very important that individuals who are in cold environments, when they put on warm clothing, they should not sweat initially, because that water is an extremely good conductive mechanism for heat transfer. Okay, as compared to air, water is far more efficient. So your own sweating, which if it makes your clothes wet, is going to make their ability to insulate you far inferior. Okay, so the skin temperature falls, the skin thermoreceptors get activated, they feed into the hypothalamus. The hypothalamus causes constriction of the skin arterioles, prevents the sweating, and causes also the increase in the tone in the skeletal muscles, sets up the shivering. The shivering increases the metabolism, increases the body temperature. And in individuals who are, having, say, a febrile response, they are going to start having rigors. Okay, so this rigor is also in a way which is a excess shivering in the muscles. And there is increased metabolic rate through the release of the TSH. The thyroid glands get activated. The adrenal glands also release more of the catecholamines, which also increases the body's metabolic rate by causing glycogenolysis and gluconeogenesis. And especially in infants who have got a large amount of brown fat, the increased sympathetic outflow increases the thermogenesis in the brown fat through the decoupling of oxidative phosphorylation. Because, oxidative phosphorylation is the process through which the ATP is generated, and at the same time heat is generated, but in a process where the body is trying to actually generate heat. And if there is a brown fat present, because in neonates, they depend largely on the brown fat to generate heat, there is a production of energy without production of the ATP, and that is called as decoupling of oxidative phosphorylation, and that is a sympathomimetic or sympathetic system dependent response. So core temperature, okay, temperature of deep tissues of the body remains constant within 1 degrees Fahrenheit or 0.6 degrees day in and day out. Okay, because that is very important for our body's homeostasis, for our body's metabolic reactions. But the skin temperature varies with the temperature of the surrounding. The skin is the our organ through which we can lose heat or gain heat, and thereby it is what is a very important part of our homeothermic response. The average normal core body temperature is about 98 or 98.6 degrees Fahrenheit when measured orally. It's higher when you go rectally. Okay, the equilibrium between heat production and heat loss determines the body temperature. And again, this is very tightly regulated. Small shifts of temperature set points occur with a normal diurnal variation, producing a peak temperature near 6 p.m. So the hypothalamus has got a set point. Okay, that is determining your body temperature at that particular moment. Now, supposing there is a change in the external environment, then the skin thermoreceptors signal the hypothalamus, the anterior hypothalamus, to change the set point. Okay, so either to take the body temperature upwards in a situation where you're dealing with a hypothermic environment, okay, or to take the temperature downward, where if you're dealing with something like a heat wave, which is occurring in India at present. So what happens is that this change in the set point is what is going to activate effective mechanisms to bring in the change in the body temperature. Okay, so normal, what happens is that if there is an increase in the surrounding temperature, there is vasodilatation and there is sweating. Okay, and there are also behavioral changes that are set in motion, because let's not forget that one is the autonomic nervous system, but there are also receptors in the hypothalamus which activate behavioral changes in the cerebral cortex, which then makes the individual move towards a warmer or a colder environment depending upon the surrounding ambient temperature. And here, if the temperature is falling, then you would be having vasoconstriction, shivering, non-shivering thermogenesis. In individuals, now, why this? The second part is showing what happens in individuals who have been anesthetized. So, we as doctors have seen that we have patients who go in for prolonged surgeries, whether they are cardiovascular surgeries or they are neurologic surgeries, and neurosurgical procedures, and when they come back from the theater, often they are extremely hypothermic, because not only is the ambient temperature cold, but the anesthesia which is given knocks out the hypothalamus, also knocks out certain temperature regulating areas in the pons, and the body is then not able to regulate its own temperature, and that can cause problems. For once, I was even called in to see a patient by my neurosurgery colleague, because when the patient came back, patient continued to ooze from the surgical sites. And in spite of, when we were checking all the whatever parameter, they seemed to be normal, until I decided to put in a rectal probe, and I found that the body temperature was 32 degrees Celsius. Okay, and that at that time the coagulation cascade was just getting affected, and that's why a person was not able to clot the blood effectively. So again, to show that even the coagulation cascade is an enzyme dependent process, and the enzymes depend upon an appropriate body temperature. Okay, so looking at the ways in which the heat is lost, about in a nude individual, 22% by evaporation of the sweat, 60% by radiation from the skin surface. Okay, and like the conduction to objects is just about 3%, and then there is a convective loss. So if there is the air currents around, okay, then there is a excessive loss of heat. So if you're standing in an environment where there is a very brisk breeze flowing, then the heat loss through the convection goes up significantly. Okay, and that's why if you see that in individuals who are, say, going to the Arctic, if they've got Arctic clothing, one thing that is done is that besides having multiple layers so as to prevent the loss of the conductive heat loss, there is also the inner lining has got gold in it, which reflects the radiated heat back into the body, because the body also radiates heat outwards, and all living objects radiate heat. Living because even that is the non-living objects would take heat from the sun or surrounding areas and radiate it back. But radiation is an important means of heat transfer, and that's why in individuals who are, say, going to the Arctic, the Arctic clothing has actually got a metal or a gold lining inside to reflect the radiant heat back into the individual and conserve the heat. So convection, radiation, conduction, evaporation, these are the main ways in which the heat is lost. So if we wish to prevent hypothermia occurring and accidental hypothermia occurring, all of these methods have to be, all of these means of heat loss have to be conserved so as to conserve the body heat and maintain the temperature. So modulators of the hypothalamic thermostat, the monoamines, the hypothalamic calcium and sodium concentrations, inflammatory cytokines like interleukin-6. We know that this is the mechanism for the fever. When there is a bacterial pyrogen, it interacts with the monocyte macrophage system, and the monocyte macrophage release the interleukin-1, 6, TNF-alpha, which go to the anterior hypothalamus, cause the release of certain enzymes which converts the arachidonic acid into prostaglandin E, and the prostaglandin E then changes the set point of the anterior hypothalamus, which conducts signals to the posterior hypothalamus, where all the integration of the hot and cold signals occur, and then the appropriate effector mechanisms are set in place. There are also core temperature receptors deep down inside in the deep vessels around the thorax and some of the deep viscera, which can also pick up what is happening to the core body temperature and send signals to the hypothalamus for appropriate corrective action. Okay. So if we have to do appropriate temperature monitoring, what are the sites? Okay, so you have core sites like the pulmonary artery, distal part of the esophagus, the nasopharynx, then the tympanic membrane. Other generally reliable sites are the mouth, the axilla, the bladder, the rectal. Suboptimal would be forehead skin, because again, skin being exposed to the ambient temperature would also have its own, would immediately reflect the changes out there and would not tell you about the core body temperature. Now, if all of us as intensivists are aware about the pulmonary artery catheter, and that is got a temperature port, which is there is a thermistor about 4 centimeters from the tip, and that body temperature is actually the core body temperature. This is the best way to measure the core temperature by putting a PA catheter in place. So if you've got somebody who's severely hypothermic, who has got severe cardiovascular instability, it makes sense to float in a PA catheter. It doesn't take much time. You just float in a PA catheter and you can get the most accurate representation of the core body temperature. Okay, esophageal temperature can be measured by using a simple probe, an esophageal stethoscope with a thermistor, or gastric tube with a temperature sensor. The sensor should be located approximately 38 to 42 centimeters below the central incisors or 25 centimeters below larynx in adults. This minimizes the effects of respired gases. Again, when you got somebody who is severely hypothermic, who has got significant multiple organ dysfunction, who may be having severe cardiovascular instability, who may have gone into ventricular fibrillation, who may be in a cardiac arrest state, it is important to have measurement of the core body temperature so that you can take appropriate, corrective steps, and also stop the steps when the body temperature starts to get back towards its normal. Okay. Urinary bladder temperature monitoring involves inserting an indwelling catheter with a thermistor or thermocouple near the patient end. The urinary bladder temperature correlates well with temperature measured at the nasopharynx or pulmonary artery and esophagus, but may lag behind during rapid warming or cooling, which is obvious because it also depends upon how much of urine is being produced. In terms of the nasopharynx, the temperature in the nasopharynx is measured with a sensor in contact with the nasopharyngeal wall, and this locates the probe close to the hypothalamus, because the hypothalamus is just present just above the nose, and that's why this nasopharyngeal method of measuring body temperature would be also telling you what's happening in and around the hypothalamic area. In terms of the rectum, electronic rectal thermometers are 2 measurement modes. There's dwell mode, displaying temperature continuously, minimum 2 to 3 minutes needed to reach a stable temperature, and a predictive mode on the basis of temperature rise curve. This requires only 30 seconds. Should be inserted at least 8 centimeters in adults and 3 centimeters. That's very important, because if you're not going to keep it relatively out, you're not going to get an accurate measurement of the body temperature, and it is influenced by heat producing flora in the rectum. So if the individual has got feces out there, it's going to be trouble, because the flora are going to multiply, that itself going to generate heat, which can be different from the core body temperature of blood returning from legs. And also, if the probe gets against the feces, is not actually measuring against the rectal wall, then also it's going to not represent the actual core body temperature. Now, this is important, that temperature regulation and age. So the ability to regulate temperature effectively declines with age. It's just a matter of whatever effector mechanisms are just going to get more and more kind of worn out. It's just whether it's your hair turning white, or you're getting cataracts, or your arteries getting stiffened. Same way, your hypothalamus and its effector mechanisms and your subcutaneous layer in the skin, etc., also start getting affected. Older individuals may not notice temperature change up to 2.3 degrees Celsius. So you will read, especially in Western countries, when there are heat waves, there's a lot of elderly individuals who succumb, because not only are they unable to regulate temperature effectively, but they also do not notice the temperature changes, because their receptor systems, their brains and all are relatively aged and not able to function as efficiently. Okay, there is an increase in the sweat gland threshold and a decrease in the volume of sweat. So that also is a problem. If you look at acclimatization, say individuals who are working in the mines in Africa, or individuals who are working in very hot environments, over a period of 1 to 3 weeks, they start to acclimatize, and the sweat gland output starts to increase significantly. At the same time, they release aldosterone, and this aldosterone conserves the sodium and chloride, and you get a very dilute fluid which is containing urea and lactic acid and all that, but at least, and maybe potassium, but at least the sodium and chloride is very well conserved. But what happens in elderly individuals, they are not able to carry out this process very well. So not only are they losing sweat, but they're losing their electrolytes, and that can cause problems. Also, other factors for altered temperature regulation include low basal metabolic rate. So individuals who have got, say, thyroid issues, or then who have got a decline in body mass, so obviously if the muscle mass is not there, how are they going to shiver and generate their body temperature? That's also going to be a problem. Okay. So hypothermia. Now, just a little bit of the background we've covered. Hypothermia is a condition in which the core temperature of the body drops below that required for normal metabolism and body functions. Okay, so mild, moderate, severe, fatal. Yeah, body temperature below 35 degrees Celsius would be classified as hypothermia. Also, the below 95 degrees Fahrenheit. So 35 to 32 degrees Celsius, that is 95 to 90 degrees Fahrenheit. There is obviously cold and pale skin because of the vasoconstriction. There is shivering. There is tachycardia because of the sympathetic system getting activated. Confusion may set in because as the brain starts to cool down, the processes, the active processes of your neuronal activity also start to downregulate. In fact, individuals who fall into very cold water, like you may have seen this famous movie, The Titanic, and Leonardo DiCaprio is swimming beside Kate Winslet. In those kind of cold waters, in 10 to 12 minutes, the brain just shuts down. Okay. So the behavioral part of protecting yourself from the hypothermia is lost because the brain itself is not able to think clearly. So how are you going to take the correct decision in order to save yourself? Okay. So you go down now to moderate. Moderate is 31 degrees Celsius to 28 degrees Celsius. So around, 90 degrees Fahrenheit to 82 degrees Fahrenheit. Obviously, now there is lethargy setting in. And what happens is that the effector mechanism of the hypothalamus, the sympathetic outflow, they start getting affected. The muscles, the glycogen start getting depleted, and the muscle tone starts to drop. The shivering starts to reduce. And at the same time, the cardiac, the heart itself, whether it's the dromotropy, chronotropy, inotropy, etc., all starts to get affected. Because obviously, as there is hypothermia, even the ATP production is going to fall. So there is bradycardia. Then the breathing also starts to slow down because the whatever ventilatory centers in the brain do not respond as well to changes in the chemoreceptors in terms of carbon dioxide and oxygen. With severe, okay, where there is less than 28 degrees Celsius or less than 82 degrees Fahrenheit, there is coma. Now there is no shivering. Okay. Edema may occur because of loss of capillary tone. Okay, there is dilated and fixed pupils, bradycardia. There is hypotension because the cardiac output starts to fall. Yeah, and even there is loss of vascular tone. There is hardly initially, of course, something called as cold diuresis. So if we are all sitting in a cold environment, yeah, you see that there is somehow there are mechanisms by which the ADH is decreased. ADH is really released by the brain. Okay, and that also causes an element of water loss through the urine. And as the temperature falls, there is tubular dysfunction. So even though the GFR may be falling, yeah, the tubules are not able to reclaim the water and electrolytes, and that also causes a significant oliguria. Yeah. Then, as the temperature falls below 25 degrees Celsius or less than 77 degrees Fahrenheit, that is the limit. Like 105 or 106 degrees Fahrenheit is the limit for upper limit. Here, about 77 degrees Fahrenheit is the lower limit, where the individual, even the respiratory centers shut down. The vasomotor center also shuts down. The heart is not able to carry out its processes, and individuals go into asystole. Prior to the asystole, they may go into refractory ventricular fibrillation or atrial arrhythmias, etc. This has got stuck here. Can you just see here? Okay, got it. Now, unintentional hypothermia. Do not forget that intensive is, where we have got patients who are coming in very sick, who may have brain injury, who may have thyroid dysfunction, who may have severe sepsis, who may have severe hepatic and renal dysfunction. They are not able to regulate their body temperatures properly. And in one study showed that in more than 3% of ICU admissions, hypothermia occurred within 24 hours. So do not forget that your own patients could be hypothermic, especially if they're elderly or they've got brain injury or other predisposing factors. And that itself can give rise to trouble. Like I mentioned about this patient who continued to bleed, though people did not understand why, and it was found that he was very hypothermic. So cause of unintentional hypothermia. Aged individuals, exposure to a very cold environment. The individual has come in with some alcohol-related problem because alcohol suppresses the hypothalamus and other regulating centers, causes vasodilatation, and causes a loss of heat very rapidly. Endocrine dysfunction, whether it is hypoglycemia or whether it's hypothyroidism or myxedema coma, central nervous system disorders, especially tumors or bleeds or infarcts in and around the hypothalamic region, spinal cord transection. So high cervical cord injury, the hypothalamus cannot send down its signals through the spinal cord because those signals especially go to the muscles to make them go into a increased tone, that those impulses are lost. And that's why individuals with high cervical cord injury are unable to regulate their body temperature. Skin disorders, very obvious. So if there is some kind of severe eczema, or if there are burns, or if there is Steven-Johnson syndrome, then again, the skin barrier function and its ability to vasoconstrict its vessels or vasodilate or sweat, all that gets affected. Yeah, general debility, well, you would not have enough of subcutaneous tissue. Trauma, especially if the trauma has caused injury to the brain and the hypothalamus. There are certain drugs. So drugs can also affect the ability to, temperature regulate, especially if they are CNS sedatives. So alcohol, phenothiazines also interfere with the ability to shiver. Barbiturates, paralytic agents are going to interfere with the ability to shiver. Okay, so they would depress the sensory afferents, depress the hypothalamus or the hypothalamic effector mechanisms, and reduce the centrally mediated vasoconstriction. Sedative hypnotic drugs cause hypothermia by inhibiting shivering, and impairing the voluntary control. So obviously, as the brain starts getting more and more foggy, one is not able to carry out appropriate behavioral responses. And paralytic agents used to suppress ventilation, prevent shivering, and eliminate all voluntary control mechanisms. Now, one of the drugs that we use in the central fevers is bromocriptine. Okay, so bromocriptine, especially in individuals who have got non-infectious fevers with cerebral injury, we use bromocriptine. And that causes hypothermia by altering central dopaminergic tone and thereby also sympathetic outflow from the hypothalamus. DKA, hyperosmolar coma, hypoglycemia, common cause of hypothermia. So, patients who come in with some of these diabetic emergencies are going to be prone to developing temperature dysregulation. Hypoglycemia lowers cerebral intracellular glucose concentration, impairs the hypothalamic because the hypothalamic neurons themselves are going to require glucose. At glucose concentrations of less than 45 milligrams per deciliter, patients fail to perceive cold environments and fail to shiver. Panhypopituitarism and adrenal insufficiency are also rare cause of hypothermia, obviously, because here the thyroid is affected. With the panhypopituitarism, the cortisol is affected, and in adrenal insufficiency, besides cortisol, they can also have, the sympathetic outflow is affected, and this, the sympathetic adrenal, noradrenal also activate certain thermoregulatory mechanisms. CNS disorders. So disease such as stroke, brain tumors, just gliosis, is what we call as leukoaurosis. And sarcoidosis produce hypothermia by direct anatomic impingement on the hypothalamus. Metabolic derangements like carbon monoxide poisoning, which is going to poison even the cerebral centers. Thiamine deficiency, because thiamine deficiency interferes with 1-carbon processing and causes, in a way, a glucopenia in the central nervous system. And, one of the extreme manifestations can be Wernicke's encephalopathy-Korsakoff syndrome or the beriberi and, the dry beriberi. And there also there's going to be a problem with temperature regulation. Multiple sclerosis by, affecting the spinal cord or these outflow pathways from the hypothalamus can also cause hypothermia. Spinal cord transection, we spoke about, because not only the efferents, but even the Skin and core temperature afferents would get affected, which are feeding into the hypothalamus. Skin disorders we spoke about, and some more can be like psoriasis, ichthyosis, erythroderma, okay, where again the skin is not able to regulate body temperature. Trauma we spoke about. So it's a no-brainer as to common effects of hypothermia. You can look at all the system, but they're looking at confusion, looking at the fact that the individuals can develop cardiac dysfunction, cardiac arrhythmias, the disturbances in the breathing, can also get affectation of the leukocyte function. In fact, one of the reasons why individuals catch a pneumonia is that the pulmonary macrophages, they do not function properly in a very cold, and especially when cold air is going into the lungs. So they're not able to phagocytose bacteria, which may be, aspirated or inhaled. And thereby, you see that the individual exposed to cold environments often land up with a pneumonia. The liver starts getting affected, the kidneys get affected, the altered drug clearance, there is a cold-induced diuresis, and obviously the gut shuts down. The pancreatic, outflow can get affected. The sphincter of body may go into a spasm, and the back pressure can set off pancreatitis. There is also a big sympathetic outflow. So there is glycogenolysis, gluconeogenesis, and there can be hyperglycemia. And of course, there can be bacterial gut translocation, which can give rise to sepsis. Okay, so, just again, some of these are, of course, repetitive, but in terms of, the pathophysiology, the metabolic changes are temperature dependent and occur in two phases. The shivering is occurring between 35 and 30 degrees Celsius. So, there is intense energy production on the breakdown of the stored fuels within the muscles. Heat production has been shown to increase by 4 to 5 times the normal amount. Oxygen consumption also goes up, metabolic rate goes up, the glycogenolysis increases the blood sugar levels. There may be, of course, an anaerobic metabolism that sets in, so lactate levels may go up, especially when there is a lot of cutaneous vasoconstriction. And the metabolic acidosis may occur because of intense catabolism and, the pyruvate being converted into lactate. And the liver kind of compensates, and the individual has to, would initially have some hyperipnea and cause a washout of the carbon dioxide. At less than 30 degrees Celsius, the shivering is now going down, oxygen consumption is dropping. Now, that is a good thing, because if you see that individuals who are severely hypothermic, you can have a prolonged resuscitation done. Individuals may have been in cardiac arrest for even up to 6 hours. But as long as the resuscitative processes are carried out, they've recovered without brain injury. So basically, hypothermia is neuroprotective and organ protective. That is why we also induce hypothermia in individuals who had a cardiac arrest in order to protect the brain. So that is it shows that, somewhere the body has its own protective mechanisms that as the body temperature is falling, the oxygen consumption is falling, and in a way that becomes neuroprotective. Okay. Now, increasing degrees of hypothermia are associated with malignant arrhythmias, depressed cardiac function, hypertension, which is very obvious. The electrocardiogram shows bradycardia, yes, because the sinus node starts to kind of, underfunction. Then prolongation of the PR, QRS, and QT, because even the whole conduction system, the dromotropy is affected. Below 30 degrees Celsius, first degree block is usual. And at 20 degrees Celsius, third degree heart block may be seen. Below 33 degrees Celsius, the ECG commonly shows the characteristic J point, Osborne waves. So Osborne waves is a way in which, if you are suspecting that your patient in the ICU may be hypothermic for those myriad reasons that we showed in the previous slides, it makes sense to do a ECG, and you will find that often the Osborne waves are present. Okay, and I will show you an example of the Osborne waves later. And they may persist for 12 to 24 hours. So basically, there is Osborne waves are due to some kind of defect in the conduction system, which is almost causing an RSR prime pattern in the QRS. Now, atrial fibrillation is common at temperatures of 34 to 25 degrees Celsius. Ventricular fibrillation occurs frequently at temperature less than 28 degrees Celsius. Cardiac output falls. Initially, the blood pressure is maintained by increase in systemic vascular resistance, but that also starts to decrease as the temperature falls and progressive hypotension occurs. So if you see out here, the electrocardiographic changes of hypothermia as temperature decreases, there is a drop in the cardiac rate. The PR and acute interval become prolonged. So obviously, there is a decrease in the flow of conduction between the atria to the ventricles. There may be greater delay at the AV junction. And then even repolarization gets affected. So that's how the QT interval starts to become prolonged. These J waves start to appear at a temperature less than 35 degrees Celsius and become prominent by temperature near 25. The J wave initially is seen as a widened QRS intervallar side ST elevation. Obviously, this is showing that there is a problem with the depolarization and eventually even the repolarization process. Okay. You can see out here marked sinus bradycardia. There is first degree atrioventricular block. Okay. This patient had a temperature of 32 degrees Celsius. There was the significant Osborne waves, as you can see the arrows out there. Okay. And these resolve with warming, but may take a while even after the body temperature comes back to normal. One has to watch out for tremor artifact because, if the individual is shivering, one may think that he's gone into a ventricular tachycardia, but actually it is just the shivering of the chest muscles, which is producing a tremor artifact that may simulate a run of ventricular tachycardia. But here you can see the QRS complex is marching through the rhythm strip. So don't mistake a tremor artifact for a ventricular tachycardia. Okay. So coming, of course, the respiratory, there is tachypnea. Initially, there is bronchoria. Then as it progresses, there's hypoventilation, decreased oxygen consumption, CO2 production, loss of the cough reflex. So very, very important is that the individual can develop a pneumonia and aspirate. So in individuals where it is a refractory hypothermia, don't forget to rule out aspiration pneumonia and sepsis, because that also has to be dealt with effective antibiotics. Otherwise, the temperature may not come up. Then there is also loss of the capillary tone in the pulmonary vessels. There is a drop in the cardiac output, the drop in the left ventricular function, back pressure into the pulmonary capillaries, and you can land up with pulmonary edema. Initially, in the kidney, there is bladder atony, then there is cold diuresis. Okay, the cold diuresis persists, and later on, as the cardiac output drops, there is decreased renal perfusion and then oliguria and renal shutdown. Initially, in the musculoskeletal system, there is increased shivering, then decreased shivering, and then the patient may appear to be dead. Okay, when they're very cold because the muscles have kind of become, almost frozen, and they may have a pseudo rigor mortis like effect. And don't forget that ATP, there is more ATP required for muscle relaxation than for muscle contraction. And that's why initially there may be a certain kind of stiffening of the muscles. Okay. Now, initially the metabolic rate goes up because of the sympathetic activity and the thyroxine release and the sugar, production and glycogen breakdown. So there's hyperglycemia, and later, of course, the metabolic rate goes down. So what's important is that, very, very important is that there are certain conditions which can further predispose to the hypothermia. Now, important to realize is that besides what we discussed about the hypopituitarism, hypoadrenism, hypothyroidism, and malnutrition, extremes of age, if they've got sepsis, if they've got pancreatitis, if they've got disseminated carcinoma, if they got severe renal dysfunction and uremia, or even if they got vascular insufficiency, because severe vascular insufficiency is not going to allow heat transfer between the body and the skin, then that can also predispose to severe hypothermia. Now, what is important is that as the body temperature drops, the individual starts to respire less and less and less, and they may almost appear to be dead. When individuals are found, by, say, with accidental hypothermia, in a non-medical environment, one has to really carefully look for the respiration, because there may be just 3 to 4 respirations occurring per minute. Okay. Now, what I mentioned about in terms of the renal function is that there is a tubular dysfunction. And this tubular dysfunction gives rise to dehydration. This dehydration, along with a drop in the cardiac output, along with then a vasodilation that occurs, can rapidly send the person into a shock and further compromise the cardiac perfusion. You can see here, one thing is that the cerebral oxygen consumption is decreasing. Now, this is a protective mechanism, okay? And when EEGs are done, when hypothermia, there is a progressive slowing of all the waves. And that can cause what we call as the so-called diffuse metabolic encephalopathy. But don't forget that this is protective, and that's why do not give up trying to resuscitate individuals until your temperature, body temperature, core body temperature reaches at least 32 degrees Celsius. Okay. Now, the WBC count in mild hypothermia remains normal to slightly elevated, but drops severely at temperature less than 28 degrees Celsius. So they become more prone to developing sepsis. Okay. The hematocrit rises because of the cold diuresis that occurs. And also the spleen contracts. You know that the spleen acts as a sort of reservoir for RBCs, in the splenic pulp. So that also pushes out RBCs, so the blood becomes more and more viscous. Now that also can predispose to problems like stroke and venous thrombosis, etc. Platelet counts drop, and then do not forget that the coagulation, the reactions get severely affected as the temperature starts to drop. So there will be a tendency for bleeding. Yeah, and there can be sequestration of platelets in the liver or in the spleen. There is ileus, pancreatic, hepatic dysfunction that we spoke about. Yeah, what's important to understand that hypothermia directly suppresses the release of insulin from the pancreas. Obviously, the beta cells may also start to malfunction and increase resistance to insulin action in the periphery. So whether those GLUT transporters or whatever get affected, but that gives rise to a hyperglycemia, at the same time, a cellular, hypoglycemia. And low sugars within the cells themselves. Yeah. And then as it gets more and more worse, the responses to the TSH and ACTH gets blunted. Infection is a major cause of death in hypothermic patients. Okay, the risk of pneumonia is increased because of the lack of the cough reflex. There may be also an increased tendency to aspirate, and also the macrophages within the pulmonary system are malfunctioning. Okay, there occurs atelectasis because of decrease in tidal volume and minute ventilation. Okay, and as the temperature drops, there is a cold-induced granulocytopenia. So that also further predisposes to pneumonias. Obviously, any kind of reparative processes are going to get slowed down, including wound healing. So, since the symptoms of hypothermia frequently mimic those of other disorders, the diagnosis may be missed unless there is a clear history of exposure or an accurate temperature reading is taken. So do not forget that you should not be trying to measure axillary temperatures in individuals who are suspected to be hypothermic, because that even oral temperatures may be misleading. Okay, and you will need special low reading thermometers to determine core temperature, because below 35 degrees Celsius standard temperature, temperature reading devices do not function or do not measure it. Okay. Now, obviously coming back, some of it is again repetitive, but the elderly, alcoholic, diabetic, those with a high cervical cord injury, severely debilitated patients, these are the guys you have to watch, because they're more likely to have hypothermia or develop hypothermia. Okay. Initially, of course, they will have cold skin, they may have muscle rigidity, and they may have acrosinus and shivering. But the patients also, as the temperature drops, become more and more obtunded and comatose. And below 30 degrees Celsius, around 27, 28 degrees Celsius, they may have fixed dilated pupils, but that doesn't mean that the patient is dead. Okay, so just examining the pupils and saying that the patient is brain dead should not be done unless the hypothermia is ruled out. And that's why if you see, even in the criteria for brain death, you cannot diagnose brain death if the patient is hypothermic, because the pupillary reflexes themselves get blunted. Okay. Now, very important is that there is an increased solubility of carbon dioxide and oxygen, and ABGs at 37 degrees Celsius may show a value of partial pressure greater than 150. Okay, so that is very, very important, that the PaO2 plus PaCO2 is greater than 150 on room air, which is otherwise not possible. So if this is greater than 150, these two partial pressures which are combined, then you have to suspect that the individual is having hypothermia. All right. So laboratory findings being, you can have metabolic acidosis, respiratory alkalosis, hyperlactatemia, initially respiratory alkalosis and respiratory acidosis. Glucose increase, decrease, no change. White blood cells, I mentioned what happens. Hemoglobin, I mentioned. Lipase may be increased due to hypothermia induced pancreatitis. Prothrombin pastin times increase in vivo due to inhibition of coagulation cascade despite normal reported values, because the reported values are done on blood which has been warmed. But actually in vivo, there is a prolonged prothrombin partial thromboplastin times. Okay, and all those ECG abnormalities that occur. So the effect of temperature on blood gas measurements is interesting, because in temperatures where, say, there is a 30 degrees Celsius, 86 degrees Fahrenheit, you will have alkalosis, respiratory alkalosis, and hypoxemia. And this is going to change as the body temperature changes. So that again, as I'm reiterating the fact that the solubility of both oxygen and carbon dioxide increases, and that is why there is something that has to be kept in mind when interpreting the blood gases. So now coming to treatment, this is a rather complex diagram, so I'm not really going to get into it in great detail here. But what's very important, okay, is that you have to measure the core temperature, okay, using a special low reading thermometer. Okay, obtain an esophageal temperature if patient is unconscious with a protected area, obviously, because when shoving it down into the esophagus, you don't want to trigger off a gag reflex and cause some vomiting. Otherwise, rectal or bladder temperature is acceptable. So first is be accurate about the measurement. Okay, then determine the degree. So are we dealing with severe, moderate, mild, or a cold stress? Cold stress is 35 to 37 degrees Celsius. Okay, there are treatment levels for the same. So the treatment levels, of course, simplest being passive, external rewarming, active, external rewarming, active, internal rewarming. Okay, and then there are the endovascular warming devices, extracorporeal circulation techniques like cardiopulmonary bypass and ECMO, and utilizing endovascular warming devices. So it's important first to measure properly, secondly to categorize properly, and then decide what are you going to so obviously if there is severe hypothermia, you'll have to decide whether the patient is hemodynamically stable or unstable. If no, then you will have to obviously carry out the BLS and ACLS protocols, and you will require the extracorporeal life support in these situations, because you will need to support the circulation, you will need to support the lungs, okay, and so while the rewarming is carried out, you're also carrying out your BLS and ACLS. In moderate hypothermia, you treat with external active rewarming, and so external active rewarming would be applying external heat. Okay, so forced warm air. Other options include heating pad or heating blankets. Okay, what is very important, and one must understand that it is important to rewarm the torso first. Okay, otherwise what happens that if you're warming the limbs first, and as the limbs start getting warm and the vasodilate, and the cold blood rushes into the body, the core temperature may actually drop. Okay, so that is called as temperature after drop. So you actually you will find that the core body temperature is dropping in spite of having warmed the limbs. So that's why rewarm the torso first to decrease core temperature after drop. Example, cover torso with heated blankets, leaving the extremities uncovered. So rewarm the torso first. Okay, in terms of the now when you're treating with active external rewarming and all interventions for mild hypothermia, that is for the moderate hypothermia, there are additional interventions like placing large bore IVs, okay? And if you cannot get an IV access, you can try intraosseous techniques to get fluid in. Important to monitor core temperatures, provide the supportive care. Now, if the warming is too slow or absent, or the patient is clinically deterioration, yeah, then you are going to go in for, again, more aggressive measures to try and build up the core body temperature, because rewarming should be at least 2 degrees Celsius per hour with active external rewarming, because that is very important. So you have to have a certain time frame in mind when you are warming up the individual. Okay. Now, I will talk about this a little bit more in detail. Okay. So we have, first of all, characterized. Okay. In patients who are not alert orientated, you will have to use appropriate temperature probes. You will have to rule out infection, hypoglycemia. And so you can send off, besides the sugars, you can send off a random blood cortisol, your whatever thyroid function tests, yeah, and a toxicology screen if there is any kind of suspected overdose. Yeah, look at the vital signs. Yeah, especially in individuals who are getting more towards moderate and severe hypothermia, you're going to have bradycardia, hypovolemia, hypotension, cardiovascular collapse, and the impaired cerebral function. 1 minute. Okay. Right. So, in terms of, again, the treatment, initial field care and transport, field management of hypothermia from exposure or immersion includes removal of wet clothes and replacing with dry ones, because water is an excellent transmitter of body heat. Okay. And then to prevent convective loss, insulate from cold and wind with the blankets. Drinking hot drinks is not encouraged because it may increase hypothermia by producing peripheral vasodilatation through pharyngeal reflex. So hot fluid meeting the pharynx actually may cause reflex vasodilatations. Precautions during transportation, so that there is no aspiration or no kind of twisting of neck, or make sure that there are no other significant trauma. Okay, transporting in the supine position to prevent seizures from orthostatic hypotension because of the cold diuresis and the drop in the cardiac output. Avoid rough handling because that can trigger off ventricular fibrillation. Okay. And if the clothing is, you're not able to get it off and it is cold and, totally sticking to the individual, cut it off. Yeah. When you're checking the blood pressure and pulse, and especially your central pulses, if you're not able to get it, the patient may already be in ventricular fibrillation and should be resuscitated until adequate ECG and pressure monitoring. Do not give up, because, again, hypothermia is cerebroprotective. Now, I just want to talk a little bit about therapeutic hypothermia here, because before we get on to the actual treatment, because one thing that we must keep in mind is that hypothermia has got its significant salutary effects, especially in individuals who are having cerebral trauma. Now, whether this usually in a cardiac arrest situation, that has become a standard of care, yeah, and where we are to make sure that we induce a cold temperature, you maintain it, and for at least 24 hours, and the rewarming has to be done in a specific manner before they're brought back to normothermic. Okay, so talking about where we are going to bring in iatrogenic hypothermia in individuals who got cerebral injury, induction is achieved by rapid bolus administration of 30 to 40 mils per kilogram. That is a 4 degrees Celsius isotonic resuscitation fluid, targeting a goal temperature around 32 degrees to 36 degrees Celsius. The maintenance phase is in the intensive care unit, is a phase where both metabolic and hemodynamic homeostasis are maintained. So you have to make sure that when you're bringing in the hypothermia, you do not sit in all those, deleterious effects which you've discussed in the past, and that can cause further problems with the individual. The core temperature is kept at around 33 degrees Celsius for 18 to 24 hours. And it's very important to maintain the brain perfusion by keeping the mean arterial pressure at 65 millimeters or more. Okay, because there can be cerebral autoregulatory failure. There can be, and it's very important to maintain a normocarbia, to maintain a normal pH. Yeah, because if there is hypercarbia, you will get vasodilatation. If you start getting hypocarbia, you will start getting cerebral vasoconstriction and decrease cerebral blood flow, maintain your blood glucose, maintain normal electrolyte status. Okay, so this is a little bit about iatrogenic hypothermia. Now, coming back to our accidental hypothermias, yeah, one thing is very important: stabilize the cardiopulmonary status, because that is what is most important. That is going to determine the outcome of the individuals. Okay, so you have to have a safe, stable cardiopulmonary status. You will have to attempt fluid resuscitation, because I discussed about the cold diuresis, and it's better to get in a central line or a Swan-Ganz catheter, because that is going to help you in multiple ways. Since most patients are hemoconcentrated and hyperosmolar, okay, slightly hypotonic crystalloid fluid should be given, and wherever possible, all IV fluid should be warmed to at least room temperature before infusion. The management of arrhythmias must be approached in a non-traditional manner, in the sense that do not give digitalis, okay, because I don't know how it would work in a situation like, say, if you're giving it for atrial fibrillation when the patient is hypothermic, and in patient with ventricular fibrillation, bretylium or amiodarone are the drugs of choice. Electric defibrillation should be probably attempted at least once, but will not succeed until the core temperature surpasses 30 degrees Celsius. So it's no use just keeping on trying to shock the patient. So keep that in mind. Huh? So if your defibrillation is not working, your electrical defibrillation, don't keep on shocking, because you're just going to be hitting the heart without actually having an effect. Yeah, and that itself will cause secondary trauma to the heart. Acid-base status and oxygenation has to be assessed. Okay. Remember, again, ABGs at 37 degrees produce different values of pH and PaCO2 than those which are at the lower temperature. Okay. Normal values for pH and pH will also change with temperature. Body buffer system respond differently at colder temperatures. When blood is drawn from a hypothermic patient and rewarmed to and measured, the solubility of carbon dioxide decreases, resulting in higher PaCO and lower PHA values than actually exist, like at present in the previous slide. Okay, again, arterial oxygen tension values reported may be substantially higher than the actual value in colder patients. Therefore, PO2 values must be corrected for temperature, and there is a formula to correct PO2 for temperature. Decrease the PO2 measure at 37 degrees by 7.2% for each degree that the patient's temperature is less than 37 degrees. Okay, prevent pneumonias. Yeah. Early intubation in stuporous or comatose patients to protect the airway and to minimize aspiration. Periodic hyperinflation, because of there is a tendency towards atelectasis. Elevation of the head of the bed, okay, to again decrease the incidence of aspiration. And antibiotics, well, if, like I said, that if you are clinically suspecting that the patient has aspirated or the patient has got sepsis, then please give the antibiotics. Just don't give it in a general random manner. Okay. Important that there'll be ileus. Yeah. So don't try to feed the patient early on. Yeah. Because that may give rise to, again, regurgitation or vomiting. Watch out for pancreatitis. Yeah. And the patient should not be allowed to eat or drink until hypothermia is resolved and pharyngeal swallow function testing indicates minimal aspiration risk. Otherwise, again, there's going to be trouble. Acute tubular necrosis can occur, and it results from shock and hypoxia. That's why it's important to maintain an appropriate cardiovascular support. Do not give magnesium for cardiac arrhythmias, because it reduces temperature in hypothermic patients who have got renal failure. So, as the magnesium levels, so that may again work counterproductive. Okay. Now, hypophosphatemia may result from the treatment, because I think once there is a kind of, vasodilatation and warming, etc., there can be phosphate which is driven into the cells. Electrolyte levels may vary greatly, and that's why it's important to monitor them at least every 4 hourly, especially in patients who are very sick. Important, don't forget your prophylaxis for deep vein thrombosis. Do not give subcutaneous heparindo for deep vein thrombosis prophylaxis, because it may be poorly absorbed because of skin vasoconstriction. Yeah, and do not place any kind of pneumatic boots on frostbitten extremities, because you will further increase the vascular trauma and cause for further tendency for necrosis and gangrene. Rewarming. Passive external, active central. Passive external least invasive. keep dry, shelter from wind, cover with blankets, okay, and allow the natural body process. So that's for somebody who's got a mild hypothermia. Temperature increase varies inversely with patient age. The average rate of temperature increase in the method is only about 0.4 degrees Celsius per hour. So it's not something which is very efficient, and that's why it has to be applied for mild hypothermia. Passive rewarming appropriate only when the patient's core temperature is more than 30 degrees Celsius. Again, in patients who have had asphyxia, where they've been drowned or there has been been under an avalanche, okay, there's somewhere in Kashmir, or unwitnessed cardiac arrest, or there has been asystole, or there is high potassium, elevated lactate or hemodynamic instability, elevated age, and elevated creatinine. This is going to be, these are red flag, okay, and these guys have to be warmed up more aggressively, monitored more aggressively if you want to have a good outcome. Now, 1 minute. I think I've just problem with this 1 second. Okay. Active external rewarming involves raising the core temperature. Dr. Tapesh, I hope I'm not tiring everybody out. Huh?
No, not at all, sir. Wonderful. Please carry on.
Quite a bit of information. So that's why I kept some of these repetitive so that it gets fixed in the mind. So active external rewarming involves raising the core temperature by heating the skin with hot blankets, electric heating pads, hot water bottles, circulating warm air immediately adjacent to the skin, or immersion in a tub of warm water. But if there is immersion in a tub of warm water, you have to make sure that the individual should not get burnt in the process. Okay, and this method works and has been successful in patients with temperature as low as 17 degrees Celsius. Mortality with active external rewarming appears to be higher than with passive or central rewarming method. This possible increase in mortality may be because of less accurate control over the rate of temperature increase, increased risk of shock from warming the skin before the core, and increased incidence of acidosis resulting from abrupt return of blood to the core from relatively hypoperfused areas. Active central rewarming is the fastest and most invasive warming method. Okay, so now we are going for those who have got moderate to severe hypothermia. And oxygen that has been humidified and heated to 40 to 46 degrees Celsius is a safe and effective method. It can be delivered by face mask or endotracheal tube. Temperature must be monitored orally to ensure that inspired air does not exceed 46 degrees Celsius, or you get burns, and you'll get burns in the mouth and maybe down there also if it's the endotracheal tube into the lung. Temperature increase with the heated oxygen usually less than 1 degree Celsius per hour. Okay. Lavage by gastric or esophageal balloons produces a slow temperature increase. Can be effective. However, the method involves risk of aspiration, and ventricular fibrillation may be triggered off during the balloon insertion. Peritoneal lavage safely raises temperature rate of up to 4 degrees Celsius per hour. So here's a picture for peritoneal lavage for hypothermia, where the peritoneal catheter is there. There is esophageal core temperature probe. This is the warmer. There's a touchscreen interface. Okay, and the warm fluid is circulated into the peritoneal cavity, kept there for a period of time, then again removed, and in a repetitive manner, this can bring up to 6 liters per hour can also be done. Okay. Then there are the esophageal heat transfer devices. Okay, again a heat exchange unit. Okay, this is the setup for that with the hose set, connectors. There is the gastric axis. Very important. This individual must be intubated, because when you're pushing something down into the esophagus, you don't want to trigger off some accidental vomiting. Then there is thoracic lavage. All right, where there are two large bore pleural tubes which are put in, maybe 36 to 40 French, and 200 to 500 mils per minute of saline at around 40 to 42 degrees Celsius is pushed in and removed, and that also helps to bring up the body temperature up to 3 degrees per hour. Okay. And then you've got endovascular catheters. Okay, so this catheter is inserted through the groin into the inferior vena cava and has got warm fluid which is circulating through the tip of the catheter. And as blood passes by, it starts to get warmed, and that also helps. very, very important to understand is that what is the risk of cardiac arrest in the individual? Okay, so if the individual is not in cardiac arrest, but if if you clinically going by one of these Swiss systems, if you feel that the individual is likely to go into cardiac arrest or is also going to kind of or has already gone into cardiac arrest, then one has to step up the aggressive treatment of the hypothermia. Now there is ECMO, which is carried out for hypothermia. And this is something which is quite effective. So especially in individuals who got severe cardiovascular instability or who have gone into severe refractory ventricular fibrillation, it makes sense to put the individual onto the ECMO. The ECMO is going to maintain a cardiovascular stability, is also going to help in active rewarming, and that you can sometimes bring up the temperature even 4 to 5 degrees of Celsius per hour, and that is also very, very useful. So keep in mind that in centers, in tertiary care centers, we've got an ECMO and an individual who has got severe cardiovascular instability, or is in persistent ventricular fibrillation, put the individual quickly onto ECMO and it will save the life, because again, as I mentioned, that severe hypothermia itself is cerebroprotective, and thereby one should not give up until one has tried hard enough and the temperature at least crossed 32 degrees of Celsius. We discussed a little bit about the iatrogenic hypothermia where we set it in motion because of for brain injury, but you can have an iatrogenic hypothermia where we have not intended it to occur. And that occurs frequently in surgical recovery rooms, intensive care units, because increased heat loss, decreased heat production, compromised thermoregulation, decreased insulation because the patients are often exposed during the surgeries. The anesthetics cause cutaneous vasodilatation. If the serosal surfaces are exposed, there's increased evaporative losses. And if there are volatile antiseptics applied to the skin, that can draw off the heat very rapidly. And then these patients have been given paralytic agents so that there is decreased heat production. And then because the sedative anesthetics are given, the afferent and efferent nerve impulses to and from, and even the hypothalamic function is affected. Okay. So in terms of preventing iatrogenic hypothermia, use of warming blankets along with heating of all infused liquids can maintain average temperature on arrival in the recovery room of 36 degrees Celsius. Heating and humidifying the carbon dioxide used for laparoscopic insufflation 30 to 30.5 degrees Celsius decreases the heat loss associated with laparoscopic procedures. Crystalloids can be easily warmed in a microwave oven to around 40 degrees Celsius in 2 minutes. The inhalation of heated humidified air can be safely applied to most intubated patients and is effective for preventing temperature loss and shivering. And meperidine may lower the shivering threshold and control pain in postoperative patients. Okay. Now, intentional hypothermia has been induced by partial immersion or surface or central cooling techniques to treat cancer, limit toxicity of sepsis, help prevent alopecia of chemotherapy, reduce carbon dioxide production in refractory status asthmaticus, assist in the amputation of limbs, and minimize the hypoperfusion injury associated with cardiothoracic surgery. Okay, mild to moderate hypothermia, of course, we talked about in terms of utilizing in cardiac arrest. Okay, cardiac arrest results in immediate termination of blood flow and loss of oxygen, leading neurologic ischemic injury. And if resuscitation results in restoration of the circulation, you can get a reperfusion injury and the activation of certain enzymes called caspases, which can give rise to delayed neurologic injury. And therapeutic hypothermia helps to prevent the secondary inflammatory cascade and progressive brain injury in patients who had cardiac arrest. Okay, of course, in patients who've had a brief cardiac arrest, if they can follow verbal commands, don't make them hypothermic. If more than 8 hours have elapsed in the return responders, it doesn't make sense because already all those reactions have been set into motion. If there is life-threatening bleeding, again, you don't want to make them hypothermic. If there is infection, that's going to hypothermia is going to interfere with the neutrophil function. And if there is imminent cardiopulmonary collapse, also you don't want to do hypothermia because that is going to interfere with the cardiac and vasculature tone. Yeah, or if there is underlying terminal condition, then if there is terminal cancer or something like some severe ILD, etc., there is no point. Benefits: hypothermia, decrease metabolic rate by 8% for every Celsius of degree centigrade that you go below 37. Brain and heart can be protected. Aerobic metabolism can continue. You reduce the free radical injury, reduce release of excitatory neurotransmitters, especially post-cardiac arrest, reduce synthesis and release of pro-inflammatory cytokines, yeah, and you can decrease ICP, yeah, so that also is useful. Very important, yeah, in this hypothermia, especially if you are taking, you're carrying it out for iatrogenic reasons. Potassium has to be aggressively replaced at levels less than 3.8, and that has to be followed because the low potassium can itself trigger of cardiac arrhythmias. Have an accurate core temperature measuring device. Yeah, with neuromuscular blockade, see that you are maintaining an appropriate neurologic examination. Watch out for pneumonia and carry out your bundles to prevent aspiration. And if the patients have been neuromuscularly blockaded, it can help to have an EEG going on to make sure there is no seizure which is happening without your knowledge. Hemodynamic instability is common during the rewarming phase because of cutaneous vasodilatation and the inflammatory state which may be there. To reduce shivering, focal counter rewarming can be employed with the face, neck, and extremities actively warmed, whereas the torso and central venous system are cool. So this is something opposite of what we are talking about, the paradoxical drop, after drop in body temperature, where the extremities are first warmed and the torso is then. Okay. So this is my overview of hypothermia. If you have any questions, I'll be happy to take them, and thank you for being patient for a big lecture.
Thank you, Dr. Kothari, sir. Can you please stop share screen, sir?
Okay, stop share. Share, please help me out with stop share. This is the one, stop share here. This one, stop share. Okay.
Just like to tell our audience why we were having this talk on hypothermia. So India is a country of hyperthermia rather than hypothermia. One, because there are areas in India, mountainous areas, where some of you will be working, so you should know hypothermia. And a lot of our army personnel work in these cold conditions, extremely cold conditions, and you may end up treating one of them. And even in places like Delhi, where the temperature drops to 0 degrees centigrade, and you can get exposure. We've had people coming in with mild hypothermia.
Yeah, more relevant for northeast, especially in the winter months.
Yes, sir. Yes, especially. That's why.
And those who are going climbing into high altitudes.
Absolutely. So mountaineering and accidental hypothermia. And of course, a lot of you guys will be taking exams. So European exams invariably have a question on hypothermia because it's very common there. So what is your experience with accidental hypothermia and hypothermia associated with disease conditions in Mumbai?
My exposure?
So, yeah, your experience. Have you had patients coming in with accidental hypothermia or hypothermia with diseases?
So see, I've had the experience of myxedema coma, where patients have come with severe hypothyroidism. I had once a lady who had come in with some 31 degrees Celsius body temperature, who was very severely hypothyroid. I think her TSH was some 130 or 140 or something. So this lady had hypothermia and, we have bradycardia. Luckily, she did not require any, besides, some passive warming and, replenishment of the thyroid hormone. There wasn't much of a problem there. I have had experience of hypothermia in patients who had prolonged cardiac surgery or prolonged neurosurgery. So that is again for all the, whatever reasons that I had mentioned in the previous slides. But again, it is important to understand that in patients who had surgery and who continue to bleed and ooze, make sure that you are bringing their body temperature back towards a normothermic state. Otherwise, their coagulation mechanisms get affected. In terms of hypothermia because of high altitude, not really, because Mumbai being a warm city, I've had patients who've been flown in from with high altitude pulmonary edema and high altitude cerebral edema, and individuals who developed a stroke at high altitudes because of cold diuresis and the hemoconcentration occurring. So I had this physician who was climbing in Ladakh and suddenly lost the power in the lower limbs and became incontinent and had developed a anterior cerebral artery thrombosis. So these kind of things are, but in terms of actually having a environmental hypothermia in a place like Mumbai, it's very difficult. But yes, seeing it iatrogenic wise, definitely in our hospital, in OTs and ICUs, etc., it's very much possible.
Right. So just talking about mixed edema coma, that is very practical because that is a real situation. And what happens is actually the sisters are not really tuned to charting hypothermia. When they see the temperature as 94 or 95, they're not confident and they chart it as 97 or something. That is what I have seen.
Correct. Yeah. Absolutely.
This is actually a problem. And this is very true actually, mixed edema coma. Once in a while in winter months, you will get these elderly ladies and they will be altered sensorium and the sodium will be low, the CO2 will be high and the temperature will be, and 96 and they'll be bradycardic. So that is how you suspect them. And then you get the temperature checked properly. You will find that it's hypothermic because the sister will be doing the routine checking with the axillary temperature and she will not even chart down 95, 96 because she will not be confident. That is what
Correct. Absolutely. Yeah.
Picked up. You have to pick it up. You touch the patient will be cold, then you get it checked either by a nasopharyngeal or a rectal probe. That's
correct. And the other thing that you have to keep in mind is that individuals who may be having hypopituitarism, right, for whatever reasons, or individuals who are having even say Addison's disease, say because of tuberculosis, etc., they also have a tendency to develop hypothermia.
Right. And just about the measurement of core temperature in hypothermia, like sir had showed, you can use a esophageal or a urinary bladder, but those are slightly impractical. A nasal probe is practically what we are using in most of our ICUs. Is good enough.
Yeah, that is a good one because it's very close to the hypothalamus.
So I will just talk a little about, sir, the target for therapeutic hypothermia, just a few lines. So first of all, friends, the American Heart Association guidelines 2020 recommend 32 to 36 targeted temperature for 24 hours post cardiac arrest in those patients who are not responding. And subsequent to that, in the year 2021, published in New England Journal of Medicine, a TTM2 trial, the largest trial so far in the post-cardiac arrest situation of 1,900 patients, showed that there was no difference in those patients who had a temperature targeted to 33 versus normothermia, that is around 37.4. So subsequent to this, a meta-analysis was conducted of 10 RCTs right from 2000, the important RCTs for therapeutic hypothermia, and the conclusion was inconclusive. Anyway, the evidence was never strong for therapeutic hypothermia. So following this meta-analysis, just this year, the European Resuscitation Council and the European Society of Intensive Care Medicine have released a statement wherein they make no recommendations for control of temperature that is inducing hypothermia after cardiac arrest. However, they do say that fever should not be allowed. You should maintain normothermia around 37.4 degrees centigrade. So these are the latest statements on therapeutic hypothermia. That is something I wanted to highlight. I'll just show you the one slide also on this. And like sir had shown, J waves or the Osborn waves, they can be seen in other conditions and they do not have any bearing upon the prognosis, but they are important marker of hypothermia. And then after drop, sir has very clearly explained, you have to watch out for after drop because the patient may be improving, and if he gets an after drop, he can have a cardiac arrest. He can suddenly deteriorate. And your drugs and defibrillation do not work at temperatures less than minus 30 degrees centigrade, which sir had shown to you. And finally, a word about sepsis and hypothermia. Sepsis classically may have a high temperature or may have a normal temperature, but sepsis can have hypothermia also. And these hypothermic patients, sepsis presenting with hypothermia, again, you have to pick up hypothermia. The sisters will not chart hypothermia. So this goes undocumented many a time. So when you get hypothermia with sepsis, they have a worse prognosis. They have a worse prognosis, and the cause for hypothermia and sepsis is not clearly known. It has been associated with elderly age, like sir has shown that these patients do not regulate the temperature so well, and outside ambient temperature. Initially, it was thought that they have a predominant anti-inflammatory response, which leads to a suppression of temperature rather than a pro-inflammatory response. But subsequently, some studies have been done which do not bear this out. So we really do not know why this hypothermic response is there, but they have a worse prognosis. So that was about all I wanted to say. Sir, you want to add anything?
No, I think that's fine. So I think, I mean, though, as what you're mentioning about this thing about iatrogenic or rather carrying out hypothermia and cerebral injury, probably now the evidence may be coming towards try and maintain more of a euthermia or a little on the lower side rather than actively pushing it, because it's also finally going to depend upon the degree of the cerebral injury occurred at that particular time.
Right.
But yeah, so though the more some of these physiologic concepts are appealing, probably the practicality may show that it may not really be helping all that much as we thought in the past.
I'll just show one slide about these latest guidelines 2022, sir.
Yeah, sure, please go.
So, are you able to see the slides, sir?
So yeah, so can you just show me the slide again, please?
Yeah.
Yeah. So I think yeah. So what they are saying is that there is currently insufficient evidence to recommend for or against temperature control to at 38 to 30. So they are themselves a little confused. In subpopulations of cardiac arrest patients, or using early cooling, and future research may help elucidate this. So we recommend not actively rewarming comatose patients with mild hypothermia after ROAC to achieve now. So I think still they do give a little bit of kind of credence that hypothermia may have some kind of protective effect on the brain, because what I understood, at least from whatever I studied also about hypothermia, that individuals, there was one boy who fell over the side of a ship and fell. It was in some freezing waters in Sweden. This fellow got fished out after 1 hour.
That's true.
And he survived without brain injury.
Right.
And we know for sure that in a situation of hypothermia, the heart and the brain both require much less oxygen. Right. So in a situation, I understand this is a very nice slide that you put up, but we should give it further thought, because if a person has had a cardiac arrest, and definitely we know for sure, I have seen patients, whether with cardiac arrest or say with traumatic brain injury, they develop secondary brain injury down the track because of release of inflammatory, enzymes and other, chemicals in the brain, which then causes further neuronal injury. So possibly, we must look at this a little more carefully, that sure, we may not push it all the way down to 32 degrees Celsius, but maybe still keeping the patient around 34, 35 degrees Celsius would probably still help having some kind of cerebral protective effect, as well as probably even a cardiac protective effect, because same inflammatory process may be triggered off in the heart after a cardiac arrest.
Yes, sir. So the thing is that there has been a meta-analysis, and that has been inconclusive. So that is why they do not recommend. It's neither this way nor that way now. Situation, and further work has to be done. So
correct. Absolutely.
We have to use our clinical sense also, like you said, sir. And I think something like 36 degree and not allowing fever would be the
most important. So I think more food for thought.
Yeah, absolutely, sir. So I think with that, there are no questions. Thank you very much, sir, for your time and your lecture. Thank you very much. And I thank the audience. So I think with that, we'll close the session. Thank you very much.
Okay, take care. Bye-bye.